Okay, so in today's lecture, we are going to discuss a very important topic, which is the postpartum hemorrhage. So, first, we are going to define it, that how much of blood loss has to occur to define it as a postpartum hemorrhage. So, if this is a singleton normal vaginal delivery, then in that case, if the blood loss is more than 500 milliliters, then this is a postpartum hemorrhage. And if this is a twin delivery, because in twin delivery and in a C-section, uh, the usual blood loss is more than a normal simple vaginal delivery. Okay, so in case of twins and C-section, we take it as 1000 milliliters. Okay, and then there is another term which is known as a major obstetric hemorrhage. So what is a major obstetric hemorrhage? When overall blood loss, regardless of whether it is a single vaginal delivery or a twin or a C-section, if it is more than 2500 milliliter, then that is called as a major obstetric hemorrhage. Or if there is transfusion of more than 5 units of blood, or if there is a fall in hematocrit, or if the patient is requiring treatment for coagulopathy. So let's say that the blood loss is not more than 2500 milliliter, but the patient has suddenly undergone DIC after delivery or during delivery and requires treatment for coagulopathy, then we are also going to consider it as a major obstetric hemorrhage. Okay, so these are all the values. Okay, if it is more than 500 milliliter, we are going to call it PPH in case of a simple vaginal delivery, and for twins in C-section, if it is more than 1000 milliliter. And a major obstetric hemorrhage is a separate term, and this is an entity that we use when the blood loss is more than 2500 milliliter, or we require more than 4 units of RBCs, or we require treatment for coagulopathy. Okay, this is it. Now the next concern is, what are the causes and what are the types? Okay, so basically the causes are very simple. There are 4 T's. Okay, we consider tone, we consider any trauma, any retained tissue, any retained placental tissue, or any thrombus. So this is the most common cause, that the tone of the uterus is lost or decreased, and this is known as uterine atony. We will discuss it in detail in a moment. And then trauma. Now basically it is the second most common cause. These points are very important for MCQs, that the most common cause and the second most common cause, and especially genital tract trauma, any sort of laceration that has occurred, any perineal tear. Now, tissue, the third T. Tissue usually includes retained placental tissue. That is why during the third stage of labor, after the placenta has been delivered, you are supposed to look at the maternal and the fetal surfaces of the placenta and look for any missing tissue, any missing cotyledon. Because if it is missing, if the surface, let's say this is a smooth surface, then this means all of the placental tissue has been delivered. But if there is like a missing portion of a tissue over here and here, and the rest of the surface is smooth, and this means that these portions, they are left inside the uterus. Okay, then you have to look inside and you have to make sure that all of it is delivered, because after 2 hours or 3 hours, after some times, it is going to cause an obstruction, or it is going to inhibit normal uterine contraction, because they like this is the uterus. Okay, don't mind my drawing. Let's say this is the uterus, and a retained placental tissue is like over here. What happens, we know that myometrium is like a natural ligature. After the baby and the placenta has been delivered, these tissues, they contract. There's like a lattice work, and they contract, and when they contract, the blood vessels that are running in between the muscle layers, they are compressed, okay, on their own. So naturally, contractions of myometrium, they cause compression of blood vessels of the uterus. So PPH does not occur usually. Like, this prevents excessive blood loss. But if there's a retained tissue, this is not going to let the contractions occur normally. Like, it has to contract like this, but this tissue, right? So it's not going to allow full maximum contraction, and this is going to lead to leakage of blood from the vessels, because they won't be compressed properly. So this was the third T, that was the tissue, retained placental tissue. Now the fourth T was a thrombus. This is not a major cause. This is on number 4 in the list. So what happens is that, let's say the same thing. There's a thrombus over here or over here. This is blocking normal contraction, normal pressure application on the blood vessel. Okay. So we are done with the 4 T's. Okay. Now let's just classify it. It is classified as either primary or secondary. Okay. Now, primary is the one which occurs within 24 hours after delivery. We are going to discuss a case. okay, of primary PPH, and secondary is the one which can occur from anywhere between beyond 24 hours, definitely beyond 24 hours, until 6 weeks or 12 weeks. Okay, we have two definitions. So some say that it is until 12 weeks, some say that it is until 6 weeks. Okay. Okay, so basically, this is the classification. Now, I was going to discuss the first T, which is the tone, which is the most important one in detail because, okay, in underdeveloped countries, a very common cause of atony is anemia. Okay, this is a very commonly asked question. Anemia leads to atony. And anemia is very common, iron deficiency anemia in women who belong to low socioeconomic causes. So it needs to be, taken seriously during gestation. Okay. Then another cause is full bladder. Whose fault is this? This is your fault. This is the practitioner's fault. A full bladder. Why are you delivering her on a full bladder? Basically, this bladder plays a very important role in our obstetric emergencies. There's another emergency which is cord prolapse. Okay. Now listen to this carefully. In case of cord prolapse, you require a full bladder. So you are supposed to catheterize the bladder, you're supposed to fill it. Okay, you fill it and then with normal saline, and then you clamp the catheter of the bladder so that it does not empty, because in case of cord prolapse you require a full bladder. This is the only case where full bladder is useful, okay, for emergency management. No, before surgery you have to empty it, but this is until you take the female to the C-section. This is a separate topic, but I'm just mentioning that you have to remember that this is the only case where you require a full bladder. Otherwise, a full bladder is very dangerous. Over here, you can see this is a very important MCQ point. Students don't concern it as an option in an MCQ. They ask that what is a very common cause of uterine atony. They look for other options, more lucrative and more pathogenically important ones. They just say a full bladder, no, this cannot be the cause, let's just move on to other thing. But full bladder is like not a favorable thing, and this can cause a very dangerous PPH, so you have to keep this in mind. Okay, so this is it. Let's just manage a case. Okay, so there's a female who delivered 2 hours ago. Okay, it was like a normal vaginal delivery, and basically now she is having excessive bleeding, vaginal bleeding, and she is hemodynamically unstable. Okay, the vitals, I'm not going to into the details of vitals. Vitals are hemodynamically unstable. Let's say they are 90 or 60 or something, like she's going to a hypovolemic shock. So she comes to you now. How are you going to manage? What is going to be the algorithm? What is going to be your approach? Okay, so very important thing in the management of PPH is that many things need to be done simultaneously. Okay, I am going to discuss these things one by one, but remember that you need helpers. One person is going to be focusing on resuscitation and passing IV cannula. The other person is going to be applying a bimanual pressure on the uterus, which we are going to discuss. Okay, so the first thing that you are going to do is that you are going to call for help. Same first step is like same in all obstetric emergencies. You call for help for a senior. Unless you are the senior, then you are in trouble. Who are you going to call then? Okay. So basically, you have to call for help, and then you have to resuscitate the patient, stabilize her vitally, 2 IV ward, the basic resuscitation steps, 2 large IV bowl cannulas, and let's just give her 1.5 liters of Dinger's lactate. Okay. I'm not going to go in depth of calculation of the fluid because that is not of a major concern. So we just resuscitated her now. And yeah, one more important thing, catheterize the bladder. I just discussed it and I forgot it myself. That you have to catheterize the bladder. This is very important. Okay, catheterize the bladder because a full bladder is responsible for atony, and that is totally your fault. You overlooked it. Now, the first thing that we're going to do is a bimanual uterine tamponade. What we're going to do is that one hand is going to be placed inside the vagina, okay, in a form of fist, okay, and the other hand is going to be over abdomen, and you're going to apply pressure. So pressure from inside and pressure from above. So it's like a tamponade. Okay, you're going to apply pressure from outside and from the inside so that the vessels in between the myometrium are compressed. Okay, so this is something that we're going to do with your hands bimanually. So bimanual uterine tamponade. This is our, like, now we're discussing specific steps after we called for help, resuscitated and catheterized the bladder. Now we are considering that the cause is atony because it is the most common cause, right? So we are going to apply bimanual pressure. Okay, this is called as bimanual uterine tamponade. Let's say that this has failed. Now what are we going to do? Now we are going to start uterotonics. Okay. Okay. Now in uterotonics, we have different options, but our option that we mostly use is syntocinon. Okay, of course, we are going to go give oxytocin. Let's say we are going to give 20 units in 500 milliliter normal saline. Okay. Always give an infusion. Okay, never give a bolus, because a bolus, no matter how emergent, how severe the condition is, a bolus is going to cause hypotension. It's going to worsen the situation. So never give a bolus. Always give an infusion.